The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, welcome back everybody to another episode of the Success in Practice podcast. Today I'm joined thankfully by Natalie Perkins. Natalie is a physiotherapist at Bodyworks Physiotherapy. Before I introduce Natalie, I've just got a couple of things that I need to fill everybody in on. We've just recently launched the Principles to Practice series. That's our face-to-face courses. The face-to-face courses that I'll be running in Melbourne, Sydney, and the Gold Coast, and so that'll be over a weekend where we will look at the foot and the biomechanics of the foot and how that affects lower limb injuries and lumbar spine injuries, and so that's called the Foot Unlocked. And then we've got on the Sunday, that'll be on the Saturday. The Foot Unlocked will be on the Saturday. On the Sunday, we've got upper limb mastery, and that's really a good practical guide on how to get success and really great outcomes with upper limb injuries and thoracic injuries. So that'll be happening in Melbourne on June the 7th and the 8th. Coming to Sydney, I believe June 21 and 22. That'll be a Saturday and a Sunday. And up on the Gold Coast, July 12th and 13th. So you can go to my website, successinpractice.net. And have a look at the courses there. Sign up for the courses. Lots of valuable information there. As you guys all know, I'm a clinician at heart. I still practice quite heavily, got my hands on and getting some great outcomes with patients. So I've taken everything that I've really learned over the last 25 years of practice and condensed those into a course to give you, I guess, the best techniques and the best approaches for lower limb lumbar spine injuries and also upper limb and thoracic injuries, and we're really going to focus on the foot in that first day, and show you how to look at the foot and really analyze it really well, and how to link that into the lower limb and the lumbar spine. Obviously, there'll be a lot of techniques shown. We're going to go through assessment. It's going to really elevate your practice. So have a look at that. That's successinpractice.net. And so, without further ado, now I want to introduce Natalie. Natalie is a physiotherapist at Bodyworks Physiotherapy. Natalie commenced her career as in a fast stream rehabilitation hospital before being offered a position at Sandringham Sports Medicine Practice, where she gained extensive experience in sports medicine. Natalie has provided her treatment methods to Olympic athletes and toured the globe for over a decade as the head of physiotherapy for Nitro Circus. She has provided physio support for a number of Red Bull Ultimate events in conjunction with Hemisphere Medical Group, who provide and coordinate services to a vast array of A-list entertainers and celebrities. She's also provided lectures and keynote speeches at venues around the globe, provided clinical training for physio students and treating peers, which included the hot topic of concussion management at the New South Wales Institute of Sport and Northern Beaches Hospital. In her spare time, Natalie plays mum to two gorgeous children and tries to practice what she preaches in terms of undertaking regular exercise in the form of CrossFit, gym, and running. Natalie, I want to thank you so much for being with me on the podcast, and welcome.
Absolute pleasure. Thank you so much for inviting me.
I guess we discussed this earlier off camera, but one of the main reasons that I'm very interested in talking to Natalie, and most of you listeners out there are osteopaths, and as you all know, I'm very all in on osteopathy, and I really love talking to osteopaths. But I wanted to get Natalie's, I guess, take on the plight of physiotherapy, I guess, and its movement away from hands-on manual therapy over the last, say, 15 to 20 years. And I guess there's lessons there for us as osteopaths, and to make sure that I guess we don't kind of go down the same path, because there's opportunity there now for us as osteopaths. So I wanted to sit down with Natalie and have a chat to her, and get her take on why she thinks that's happened, and what lessons we can draw from that. And so before we get into that, though, the listeners are always interested, Natalie, in your backstory. We want to know a bit about you, your early influences growing up as a young girl. Tell us about your high school years and what attracted you then to physiotherapy.
Um, yeah, well, I'm fairly old in the tooth now, so I can scarcely remember my childhood as that long ago. But I actually was going to be a pharmacist.
Right.
When I was about 16, I went, right, yep, going to be a pharmacist. Love to do that. That's amazing. Got my life all sorted and planned out. So off we go. And I happened to go to a careers night at our school, and they had all of the different careers were represented by people at tables, in alphabetical order, set up in the school hall. And so I made a beeline to pharmacy and listened to the lady there for about 5 minutes and went, oh God, I don't want to do this. I had my first of many midlife crises and went, what am I going to do with the rest of my life? That was what I was going to do. So thankfully, physiotherapy is spelt with the same initial letters as pharmacy, because I went literally one desk to the right and started to listen to that lady, and there I stayed. So that was how I became a physio.
Right.
Um,
You could have gone one desk to the left and spoken to the osteopath.
Correct.
Right.
So, it is the pickle finger. I can still not remember my left
Yeah.
and my right. So I could have ended up there, and I would have been very happy doing that. So I'm very
Right.
fortunate to have worked with some fabulous osteopaths, not just in Australia, but overseas as well.
Great.
So I have a great knowledge and respect for your profession. So would have been happy with either choice.
And so where did you end up studying your physiotherapy degree?
So I grew up in Melbourne. So I studied at Lincoln Institute of Health Sciences before
Hmm.
it became affiliated with La Trobe University. So that was a very long time ago. And most of my peers got into physio because they wanted to, they were all sporty and they wanted to work with, elite athletes.
Mm.
I decided I wanted to do pediatric physio. And I thought that the best place to work would be the Royal Children's Hospital in Melbourne. And I knew that it would probably be a very sought after position. So during one of the university Christmas breaks, I volunteered for 3 months at the Royal Children's Hospital, thinking, well, if I get in and learn a bit of stuff, maybe learn the staff members, when my application comes in however many years' time, maybe hopefully they'll recognise that, I'd worked there and I'd shown keen interest. And that was my second midlife crisis, because I suddenly realized that I sucked at kids. I I didn't know how to talk to them in an engaging way. I couldn't do the baby talk, and more than anything, I really didn't have the heart for it. It was, I basically went home in tears pretty much every night, and I went, I can't do this for the rest of my life, and took my hat off to the people who could. So then I was like, well, I'm now doing physio. I better stick with it and then see where this takes me. And most of my peers, as I said, wanted to work with elite athletes. And I remember three of them wanted to be, they were absolutely 100% positive that they were going to be the physio for the Australian cricket team. And to this day, I've often wondered what happened to them, because there was a gentleman by the name of Errol Alcott who was in the position for the better part of 25 years. So I'm fairly confident that those three peers never got to work with the Australian cricket team. So I think, we all start off in one direction, and some of us go in the direction that we think we're going to go in, and some of them, like me, end up in all sorts of weird places.
Well, I'll ask you about that in a minute, because that's interesting to me too, because I think people have this pipe dream where they think that working with elite athletes is somehow glamorous. And, and you laugh because I'm laughing at the same thing too. It's definitely not glamorous. It's dirty, it's smelly, it's stinky, it's unappreciated. And people have these grand visions of running out on the field and carrying the trophy with the team. And that's not what happens. So, but I'll discuss that with you in a minute. But I want to keep you on track with, I guess, your time at university. and the people that you, because this will lead us on to our conversation, I guess, about hands-on practice. Tell us about your time studying as a physiotherapist, and if you've had any experience with education now, how do you see it as being different, your days versus what's going on now? Like, what were your days like at university? Were you very hands-on? Were you taught a lot of manual techniques? Were there a lot of early influences? Were there a lot of mentors? Do you remember the people that really influenced you? Talk to us about that.
I believe it's very different from how it is today. So, I mean, I studied back when the Earth was still flat, um, and times were different, and we did an awful lot of manual therapy. Like, we got very involved in biomechanics. We were very involved in anatomy. Like, we got to do a whole
Mm.
cadaver study, which I think was it's just so it's invaluable. Like if you don't know, I say to my students, if you don't know what's there, how can you possibly know what's wrong with it? Whereas today, I think they skip over it. There's so many more courses now. When I studied, it was just the Melbourne course at Latrobe, sorry, not Latrobe, Lincoln. Um, Everybody from Tasmania had to go there, and it was the only course in the state. Now I think there's half a dozen of them. They have changed. We got access to the best teaching hospitals in Melbourne because it was the only course. We got to study fairly closely with the medical students, so we got to develop those relationships whilst we were studying. Now I think there are so many courses, and certainly from what I witnessed in Sydney, Sydney University has the main relationships with the major teaching hospitals because of medicine. So the physios that go to Sydney University get that experience, whereas the other courses get kind of like, I don't want to say second-rate hospitals, but certainly not the teaching hospitals. And I think the same thing has happened in Melbourne. So I think that's a huge difference. We touched on research when I was studying. Back then you had to get what was it called? There was a light machine that you had to look up a research article and go over into an actual library and pull something off the shelf and flick through until you found some research paper. So it was very, very difficult to get hold of research, and there wasn't a lot of research being done. Now it's like that's the only thing they talk about.
Mm.
Is what does the evidence say? What does the evidence say? What does the evidence say? So I have to unteach a lot of that. Not that I dismiss the value of research. I think it's incredibly important, but I think we've gone too far into thinking that now research has to dictate therapy. And
Mm.
I remind people that you have to come up with the idea, implement
Mm.
it, and then research it to work out does it work or not.
Mm.
Whereas the way they're teaching it, I feel like it's the cart before the horse now. It's like they're sort of suggesting that you can't do something until research proves that it is valuable.
Yeah, like it's the good therapy comes from the ground up, you know.
Yeah, absolutely.
It comes from the therapist doing the work on the ground. A lot of, they get great results. They go, oh, there's something to this, but to go investigate that. And even then, it doesn't happen then. They go and talk to their buddies over a drink and say, I've been doing this. Oh, yeah, well, teach me. And you'll teach your friends and they'll start doing it. And they go, there's something here. Then you might do a couple of case studies, right? And then you get those going well. Then you might do a little group, maybe a longitudinal study or something like that. And if you're lucky to ever get to an RCT, with funding and time and all that kind of stuff, then and that's a span of maybe 10 years, 10 to 15 years, I think, especially if you're in private practice. And so if you wait for the research to dictate what's going on in your practice, you're going to miss out on helping a whole bunch of people.
Absolutely. And to me, the most powerful proof is the patient in front of you. And,
Mm.
our job is to make sure that they feel better when they walk out than when they walked in. So if you're consistently doing that,
Mm.
then yes, I find it scientifically intriguing to kind of read the research and go, well, what do we think is going on? But at the end of the day, not a single person understands how the human brain processes the electrical signals that it gets.
Mm.
And because we don't understand processing, then everything that we have is a guesstimation. And this is why I think you have so many different philosophies in medicine. You know, we're all, the way I say it is, it's like religion, right? We're all praying to the same God via a different pathway. And sometimes I think we get caught, as with religion, arguing about the pathway rather than understanding that no, that's a process. And as long as you meet the end goal, does this patient feel better? Have you made their lives easier to live? Then job well done. And I really don't care how you go about it, as long as every single patient that you interact with is better for your interaction.
Well, that's ultimately the only real evidence in front of you. I mean, if the patient's better and happy about what they've received and they've improved, and you build upon that, it's like a good workout is made up of really good repetitions.
Yeah, absolutely.
So you get the rep right, and you rinse and repeat and get that done right, you end up with a good workout. And so, you get a treatment right, you rinse and repeat and tweak it for each individual patient. And all of a sudden you've got a great day, and then you get the day right, and you get the week right, and then you get your month right. And then, things grow from there. And you're right. I think practitioners across the board, physios, osteopaths, chiropractors, you throw some EPs in there now, if they're kind of getting into a lot of the, treating injuries and so forth, given that their approach is correct and they're applying kind of good treatment rationale, we might have different pathways of getting there, but we all should get to the place where the patient is improved. So that's you're not wrong there. Were there, I guess, in your time when you were studying, was this discussion kind of alive in terms of the, making sure that you were practicing with a very hands-on approach? Was that emphasized with the people that taught you? Because we may be going through it at the moment, but in those days, I mean, we're talking years ago, was it emphasized that, hey, you really needed to get your hands on palpation? Was palpation something that, was it emphasized that you needed to get your hands on patients to really know what was happening at the tissue level?
Palpation was everything. Like we spent hours doing palpation. We spent hours doing assessments. We spent relatively little, like we did do exercise prescription, but I'd say we had a much stronger leaning towards the manual therapy, and clinical reasoning, probably, and to some extent learning how to learn and join dots, rather than being handed protocols to apply. And again, one of my concerns is we now seem to be in a world of make the diagnosis, work out what the protocol is according to the research, and then deliver that. And it's like, well, yeah, it's like that can be not a bad place to start if you're not really sure, but you'll often find that these protocols, that it's like saying, well, we've worked out the best shoe and everybody just needs to learn to fit it. It only comes in one size because we've determined through research that that's the best size. It's like, right, well, it'll fit a lot of people, but there'll be a lot of people that it'll be really uncomfortable for. So stop giving them the same damn shoe when it doesn't fit them.
Yeah, well, they're usually the people that are seeking you out too, because, I mean, that's why they're in trouble. If the shoe fit, they wouldn't be in trouble in the first place.
100%, yeah.
Yeah. Who were some of your early mentors back in those days that you really looked up to, that taught you a lot of the palpatory skills and a lot of the rationale that you kind of take with you today?
Well, I guess we learnt a guy called Maitland, Jeff Maitland. He's kind of underpinned physiotherapy, like traditional physiotherapy. He wrote a book and we all studied his method. And I feel like in physiotherapy, if your name doesn't start with M, then you're never going to make it, because you have to be Maitland, McKenzie, Mulligan, Mosley, Adam Meekins. Not that you'd want to really listen to too much of him. Yeah, you have to start with M. So as a Perkins, I'm, one letter off. One letter off. Yeah, but it was like, it's that left-right thing again. I could have been an osteopath, but I'm a physio.
Yeah, that's right. That's right.
So I guess we never really thought about, well, I certainly never thought about the concept of a mentor. These were just, I guess, the world according to these people.
Right.
we didn't get mentoring as
It's
we.
not so much a mentoring as in a single person, but I mean, I guess when you're, I guess, an early graduate and you're really trying to navigate practice, whether it be in hospitals or private practice, sometimes you don't know what to do. And if you've had some people that have taught you, I guess you kind of close your eyes sometimes and go, well, what would they do? And that kind of just gets you over that little bump, build some confidence, and then off you go. Was it something that you experienced? I mean, when you were kind of starting in practice, I know the difference might be, it might be a little bit different with physiotherapy because there's a hospital component to that, and you get to go into hospitals and you get to apply, I guess, you get to apply your trade to people that you don't have to do very much to get a improvement out of them. I mean, if you're in hospital and you've broken a limb or you've had a hip replacement, a little bit of movement is going to make such a big difference in your life, you know?
Oh,
Uh,
absolutely. I mean, I think inpatient care is not as I don't want to say it's difficult, but you're not having to make a diagnosis. The diagnosis is essentially given to
yeah.
you. That said, we had to do outpatient, which is just like private practice, basically.
Mm.
So there, yeah, people would come in with ankle sprains or sore backs or, absolutely no different from what you would see in private practice. So
Mm.
we were fortunate in that our final year was pretty much entirely in the clinical environment one way or another. So we got forced to practice and we were assessed on our outcomes to some extent. Whereas now you're not really assessed on outcomes, you're assessed on, you know, do you cerebrally know what to do? And in theory, could you do it?
Mm.
But they don't do practical exams like we used to have. We had grueling practical exams.
Yeah,
Um,
that's been the feedback from osteopaths of that vintage as well, that the
mm,
exams in those days were very outcome focused and very kind of grueling to an extent where you had to, the pass mark was quite high. Um,
yep.
and I think that's across the board, probably not just even in health sciences. I think across a lot of things like engineering and architecture and a lot of the STEM fields were very, probably a lot more grueling. I want to ask you about your journey, your particular journey into early practice. You said that you worked at Sandringham. Tell us about those days as an early graduate and your time, I guess, in practice. What were they like?
Well, getting into private practice was very difficult when I graduated. You had to have experience, and it was way easier to get a public sector job than a private sector job. So when I started, I took a full-time position at the Fast Stream Rehab Centre. And then a couple of months in, I got a phone call from Sandringham Sportsmed where I'd done one of my clinical placements. And they said, would you come and work with us? But we only need you part-time. And I went, oh, well, I can't afford to only work part-time. And I knew it was going to be very difficult to get another private practice part-time job to fill it. So I said, yeah, but what sort of hours do you want? And they said 5:30 till 10:30 p.m. Tuesday, Thursday, and 10 till 4 on Sunday. So I said, no problem. I'll be there. Now, I was lecturing on a Monday night, anatomy and physiology at Monash University. I looked after a football team on Wednesday night and Saturday afternoon. So I worked essentially 7 days a week.
No social
Um,
life.
oh, yeah, I
That's
still went on Friday night and Saturday night.
that's
I
the
went
no
to
social life shift. Yeah,
went to the gym at 6 o'clock every morning.
yeah,
That was great.
yeah.
And I loved every minute of it. So I found it invigorating. And then after I think 2 years of doing the 7 days, I then switched to full time in the private practice
Yeah.
and continued working 6 days. And they were 10-hour days.
So
Um,
they've knocked on your door and asked you to work part time. What is it about your practice and your evolution that you think then allowed you to, or for them to kind of go, hey, you've got something here, Natalie, come work full time? Like, how did you develop as a practitioner that made them think that we've got somebody that can do some good work? Let's get her on board as part of the team and not just use her as somebody who's filling in the gap, the after hours shifts.
Yeah, well, I feel like I was very, very lucky that fateful day when I did one table to the right. Um, I fell into a job that, as I said, it's as much as a hobby as a vocation, but it took me many years to work out that I have intuitive feel, and that part of what we do with manual therapy, it's as much art as it is science.
Hmm.
And I often have patients go, but yeah, but why are you so different from the other people that we've had, that put hands on? And I go, well, it's a bit like who taught Adele to sing a note that gives you goosebumps? Um, Nobody did. For some reason, she just naturally sings that note, and everybody can sing that note. I can sing it too. You just wouldn't want to hear me.
Yeah.
Um, what is it about these musicians? What is it about your Van Goghs and your Mozarts and your Monets and your Jackson Pollocks and your Picassos? And they have, you can only describe it as an X factor that is art that can't be taught. It happens intuitively. Um, Now, I think a lot of people have it. And certainly when I have interviewed for staff over the years, I look at their CV for all of about 30 seconds and then I get them to treat me.
Mm.
And I don't necessarily expect them to know what to do with their hands. I'm happy to teach that. But I have learnt that if they don't have feel, I can't teach them feel.
Mm.
They don't know it if they don't know they haven't got it if they haven't got it. It's like you don't know what you don't know. And I can direct their hands. So if I'm getting a sense of, okay, they've got something here, they just don't know what to do, then I start teaching them literally in the interview. And I'm like, are you teachable with this? Are you connecting some things? Can I like, am I the right sort of teacher that can drag something out of you? Because it's not always them, it's me. I've got to be able to
Mm.
enhance what I see. Um, and I still remember there was this one guy who had ticks in every single box. I mean, bless his cotton socks. He turns up in a suit and tie, done up, to a physio interview. A couple of years later, a bloke turns up in a hoodie. And I'm like, really? Like, the suit and tie is not necessary, but neither's the hoodie. Anyway, this guy, lovely, lovely, lovely human. And I was like, yes, I've struck gold. He's going to be fabulous. I tried to teach him for over an hour during the interview process to get something in his hands that I can work with this, I can develop this. And he had nothing. And I didn't hire him.
Yeah.
Because that's what our clinic is. It has its reputation based on good manual therapy.
Mm.
And again, I've probably chosen some staff members who haven't been a good cultural fit, but they've had great feel. That's caused its own issues. But the patients were happy. They were just hard to work with. So it's a very difficult question to answer because I think you can't define it. And this is why I think from a research perspective, it's way easier to do 3 sets of 10 reps of a defined weight and be able to reproduce it with multiple different people. I mean, how I put my hands onto you, yes, we can all do the same technique, but as you would know yourself, different hands give you a different outcome. Different hands give you, the patient, a different feel. And you'll be there going, yeah, that feels really good. And somebody else doing exactly the same thing, you go, yeah, that just didn't feel as good.
It's talent. It's talent, right? Like, we see football players and soccer players and actors and artists and like you mentioned and musicians, and some have talent and some suck and some are somewhere in between
Yep.
that kind of try, and why would we be any different? You know?
Yeah,
Um,
absolutely. And I think we're very comfortable with acknowledging that for all sorts of other professions. But when it
mm,
comes to things that are studied at university, you've all received the same information, so you should all be equally as good. And how dare anybody say
yeah.
that they might be a little bit better? I mean, that's what Charlie Teo got hit with.
Yeah, well, that's
Heaven,
APRA as well, isn't it? Like they're trying to
yeah,
level out the playing field, and you can't say that you can get great results with one particular thing because that you're not allowed to kind of say that. So yeah, they're trying to have a level playing field. But we all know the playing field is not level.
mm,
The public figures that out really, really quickly, and some people, I guess, are on a similar level in terms of talent. And I guess patients will just sort themselves out based on how well they connect with that particular therapist.
Yeah, and I think that that connection piece is again super interesting because I think when I was younger and I just succeeded and succeeded and succeeded with patients, I'd be like, oh, I'm just really good. And then after a while, I went, hang on a minute, this is a word of mouth business predominantly. So what if really, like, when you think about why am I friends with whom I'm friends with? Of all the people on the planet, I choose these people because I have a connection with them. Like, you know, we can get like into even quantum physics with this.
Yeah.
I have a connection with them. Why? Like, why do I choose these people? I don't know. They just like, I like them. I don't like these other people. So then I went, well, maybe the reason why I'm succeeding with this cohort of patients is because for whatever reason we have an attraction and they're sending their friends or their family member who is also at the same level. So because over the years, I've looked at other therapists that do very, very different stuff from myself. And I go, well, they're still succeeding. Like they're getting people better, but they're not doing what I'm doing. Same with osteopaths. Like I do a few osteopathic techniques, but I'm like, but not for every patient. And you go, well, okay, if physio is the best of everything, why do osteopaths work? You know, how come patients go, oh my God, my osteopath's amazing. And you go, yeah, you've found the right therapy for you. So I've now started to say to patients, look, it's like asking the world, what's the best restaurant in Sydney? Oh, well, it's Tatsuyu's, although I think that's closed down. And I go, well, yeah, but I don't like Asian food.
Yeah.
You know, and it's like, well, what is it that makes us like a particular food? What is it that, like, there's so many ways that you can look at this. It's a very complex topic.
Yeah, if the patient also, if you're anywhere near decent and talented, I think if the patient gives you, you know, enough leeway, you know, 3 or 4 sessions with them, you can tend to figure out their tissues, you tend to figure out their problem, their strain patterns, and then off you go, right? Like if you get that leeway. And so I often say to patients that ask me, you know, especially people from other parts of the country or that don't have access to me, and they'll say, oh, how do I find a good therapist? I'm like, well, you know, sometimes a therapist is good. You just got to give them a bit of time just to figure you out. And once they've figured you out, don't let that therapist go because, you know, you've kind of like, you've hit the jackpot there. And so, yeah, no, that you're right in terms of the talent. You're right in terms of having the connection with people and kind of building on that. I want to ask you about your particular, I guess, time in physiotherapy and some of the things that you've done. We briefly discussed your work with athletes and with sports people. So I want to ask you about that. And I guess I mentioned that it's not very glamorous. It's not very rewarding sometimes. What can you shed some light on that and talk to us about, I guess, what it's like to work with athletes, work with teams? What's been your experience?
Yeah, well, as I said, I really had no desire to, well, no great life goal to work with athletes, and then found myself at Sandringham where we were surrounded by, you know, elite athletes. Interestingly, after 2 years of working predominantly with high level athletes, I actually got quite bored because I'm like, hang on a minute, I'm dealing with a patient population that has above average strength, above average motivation, above average body awareness. For a lot of them, they could see me twice a day if they needed to. If they weren't with me, they were at the gym, the pool, or the hyperbaric chamber. And their full-time job was to get better. And I went, if I can't fix this, I suck. Like,
and then get worse. Their full-time job is to get better and then get worse. And then get better again and then get worse.
Yeah, but and then I'd kind of come across a single mum with 3 kids who works at KFC who's rolled her ankle, and she's not going to get paid if she can't turn up to work, and she can only afford to see me once. And I'm like, right, that's a challenge.
That's pressure.
that's pressure, and I loved it. Like
Yeah.
I wanted the challenge. I needed the challenge. Um, that's one thing. Another thing, I think, certainly in the physio world, it's a who you know, not what you know most of the time. Like most of the time, people get these gigs because they know somebody
Mm.
in the club. It's not like they advertise the position and we all turn up with our hands and treat a bunch of athletes, and then the athletes go, "Yep, this I feel the best from this particular candidate."
Mm.
It's nearly always done also on paper. Um, you
Yeah,
know,
it's a big boys club,
yeah.
and they get their mates in, and there's nothing like, intrinsically, all other industries are the same. Networking's involved, and if you're a good networker and you keep good networks around you, you're bound to get a foot in the door. And so I'm not having a go at that, but I always say that the best and brightest aren't really the ones that are in those clubs doing the work, because the best and brightest are usually very, very busy in their own private practices. They don't really have the time to go out to 3, 4 nights a week of training and fly around the country with a sports team, especially if they've got a young family. And also sponsorship plays a role in that now, I think, too.
Mm.
Most physiotherapy practices, health practices, allied health practices will generally sponsor the club that they're working for, and that's a sure way to get in the door and have them as part of the medical team. Has that been your experience, Natalie?
Yeah, absolutely. And I think, I learnt from working at Sandringham and then, when I moved to Sydney, just watching some of the other businesses that, like, it's not a very lucrative, like, there's a supply demand issue that if there's hundreds of physios who want to be the physio for the, I don't know, Hawthorn Football Club, um, then there's a massive supply of them. So you don't have to pay them very much. And certainly back in the day, we did it, all the sports stuff for free. If you wanted
Mm.
sports coverage, you did it for free. And even today, sadly, it's not too much different. So it's not lucrative. It's horrible hours. And if you don't know somebody, then it's pretty challenging to get into the elite
Mm.
teams that people seek. And I guess that was the thing with Nitro Circus was, I treated the COO's wife and got her better. She'd seen heaps of therapists before me. She then sent her mum, and I got her better. And then they both sent the COO, and I got him better. And then he just rang me when back then they were promoting the Crusty Demons. And he rang me from Melbourne saying, can you come? No, he didn't say that. He said, "Oh, the boys are falling apart. Can you recommend somebody that does what you do?" And I said, "Well, look, I trained in Melbourne, so and I hope some really lovely physios, but I can't guarantee that they do what I do because I veered off a little bit from when I trained." And he said, "Well, no, we want what you do." And I said, "Well, then you're going to have to fly me down." And I was actually joking.
Yeah.
But he said, "Book the flight." And then they went to Brisbane after Melbourne, and he rang on the Thursday and said, "Oh, can you come up tomorrow?" And I went, "Yeah, okay." And then we went to Adelaide, and then they were the same promoter that then started Nitro Circus. So all of a sudden, I was just part of the group. So I sort of feel like in that respect, I actually earned the position rather because I didn't know anybody.
Yeah.
But most of the time it is who you know. I mean, we sacked a physio, lovely guy, but we sacked him because he was a useless physio, and he became the physio for one of the professional football teams up here in Sydney.
Right.
So you go, well, that's kind of proof that it's who you know, not what you know.
Yeah.
So,
It's a funny conversation. I can imagine that conversation on the phone. Look, our trapeze artists and gymnasts are falling apart. Some of the carnies need some work. Was that? It's. What
okay,
was
so
it?
that
What?
tells me you know nothing about Nitro
I
Circus.
don't. I don't know anything about it. It's just my education on the circus is from Looney Tunes and
Yep,
and the very few cartoons that I watched as a young boy. And
yep,
so I have
no,
this thing in
no.
my head, and that's why it's a little bit funny. But please, this is leading on to a question.
Well,
Educate
hang on, I'm going to
me and
stop
my
you there.
listeners. Yeah.
Yeah, because focus on the nitro part, not the circus part.
Right.
So nitro circus, the vast majority of the athletes flip motorcycles in the air and land them after going 2 stories
Okay,
up.
there we go. I was thinking of some totally different. I was actually thinking the Russian type Bolshevik type
Yeah,
circus. Yeah, that's
no,
okay. Right.
no, we're
Okay.
talking mad adrenaline junkies, action
Great.
sports. Travis Pastrana was the guy that started it all over in the States. So,
Yeah.
yeah, there's not much circus
The
involved.
closest I got to that in practice was actually I treated one of the executives at Yamaha,
Mhm.
and they sponsor a lot of the motocross and the guys that would go out there. They would, I think they used to come out to the old Parramatta Stadium in Sydney, which is now Combank Arena, and they used to turn that into a big kind of like motocross, big kind of flips
Dirt
and
pit.
yeah,
Yeah.
dirt pit, and the motor guys would just go crazy there. And he sent over one of the guys, I think it was a Kiwi guy. I'm trying to remember his name, and he had a fractured collarbone, multiple fractured collarbones, and dislocated shoulders, and these guys just beat themselves to like trauma, real trauma stuff, and their tissues were just like really kind of elastic and just kind of bouncy, and you'd kind of move a joint and it would just bounce right back. It didn't want to do what you wanted it to do. So I've got limited experience there, but I guess you being there and seeing all that, um, did that, I guess, how did you take the information you learnt there back into your private practice? Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also, in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
Yeah, that's an interesting question. Um, I think that it gave me a great opportunity to have a heap of crash test dummies.
No
When
pun
we would,
intended.
yeah, no, quite literally. So I do this really gnarly ligament treatment that hurts like hell. It's one of the worst things I do, but picture this: you're on tour 3 weeks, maybe in Europe. There's a show every night or every second night. The guys earn about 2 grand a show, but they have to perform all of their tricks to take the money home. It's no work, no pay. They roll an ankle day one, and that traditionally would take them out for 3 weeks. So do the maths on 2 grand a show
Mm,
it's a big chunk of change that they're missing
yeah.
out on. So I developed a technique which I initially did on myself, on my knee, And then I went, well, one of the guys hurt his ankle, so I tried it on him, and he screamed and just about punched me. But then got up and ran back up the ramp, and off he went. So um, I guess those sorts of techniques, like knowing that you have to make a difference in a very short space of time,
Mm.
um, that meant I could bring those things back into the clinic for, and it might not be an elite athlete back in the clinic, but it
Mm.
might be somebody who wants to be able to play soccer on, the grand final on Saturday, and they've tweaked their ankle at training on Thursday night, and they're coming in limping, going in tears. Well, I might not make the grand final, and I'm going, right. Well, keep
Let's
those
try
tears
this.
rolling. Yeah,
Yeah.
keep those tears rolling. And they literally run out. Like, it's quite fascinating, but it's
Yeah.
it's the ultimate cruel to be kind. So I think those sorts of things, definitely that need to be able to make a difference really quickly. And
Mm.
again, it's that high pressure, high challenge, thinking on your feet. That's the sort of stuff I loved. Um,
Have you, I guess, one of the things that I stress about with my students is I discuss with them the knowledge of stress application, like how hard to press. I mean, you just touched on a technique there that you developed based on, I guess, applying a huge amount of stress from what you're describing to a ligament to get it to respond. And so, is that something that I guess, was that an aha moment for you where you said, hey, a lot of the times we're told to time, rehabilitation, very gradual kind of incremental increases. But then you went, you know what? I'm just going to apply a lot of stress to this and see what happens. And you got some great results. And then you started to apply it across the body. Would that be a correct definition of what
um,
you were talking about?
Sort of, but I think it related more, not so much to, like, people would see it as aggressive because it was painful. It was more about the wear and the angle.
Hmm.
It's actually, from my perspective, quite a gentle technique. It's just it hurts like hell, so everybody assumes you're in there kind of like, ah.
Hmm.
Um, so I think, yeah, it's
Well, that's why I
it
use the word stress application.
Yeah,
It's
yeah,
not,
yeah,
yeah,
absolutely. I think it comes back to, again, our lack of genuine understanding about the nervous system, and manual therapy. When you look at all the various receptors that are present in various tissues, I still don't think we have a really good bead on what they all do, and the signals that they give. And again, how the brain, once all of those signals get up there, how the brain processes it and has a response to it. Because, I've certainly come across the odd patient where manual therapy seems to be the worst thing for them.
yeah.
Like, when I touch them, it's like I can tell the tissue is just going, you know what, piss off. Um,
Hmm.
and so I'm like, okay, we need to definitely handle this very, very differently. It's only a small number of patients, but I have to really change up
Yeah.
what I'm doing there. So I think that capacity to feel the tissue and to almost listen to it. What's the story the tissue's trying to tell me,
Mm.
and work with that is probably a good summary.
All right. You mentioned earlier that you've worked with osteopaths and you've had some, I guess, direct kind of uh, working alongside osteopaths. Sorry. Um, Tell us and you said you've mentioned that you've used osteopathic techniques. Can you give us some insight as to what you've learned, what you use, and I guess what was your experience working alongside osteopaths?
Yeah, well, I think when I was at Sandringham, my boss the name of the guy. Everyone called him the Bear because he was a great big guy. I don't actually remember his real name, but he was from America, and my boss Phil flew him in to teach us muscle energy.
Right.
And
How long ago was this?
33 years,
Right.
something around there.
Okay.
Um, and yeah, no one was doing it in Australia. So I was amongst one of the first, but I don't even know that osteopaths, like, they almost didn't exist back then. They
Mm.
were a very fledgling in Australia, a very fledgling profession. I
Hmm.
think just a handful of osteopaths back then. I certainly hadn't heard of them. So when we were having this osteopath come from America, I remember going, well, what's an osteopath? Like, don't even know what they do. Didn't really care because it's like, oh, what he taught us was super cool. And oh, just a completely different way of thinking about, the pelvis and the
Hmm.
interactions between the pelvis and the back. And I certainly used that technique, for example, quite a lot. I personally that found it was a good get out of jail free card, as in you get a good quick fix, but I found that it didn't stick as well as some of my other treatment techniques.
Hmm.
To be honest, I put that down to my lack of genuine mastery of the technique rather than
And you're
there
talking
being
about muscle
anything.
energy technique,
Yeah,
right?
rather than there being anything actually wrong with the technique, I think it was the technician that was the problem. So,
So can you, I guess, being a physiotherapist and learning a bit about it and applying it, can you contrast that technique with PNF? What physiotherapy would traditionally call PNF?
um, well, I guess I summarized it as, yeah, no, it's PNF or contract relax.
Mm.
So we're talking reciprocal inhibition or contract relax as the fundamental physiology underlying the muscle energy technique.
Hmm.
So I think when we got taught it, they made it way more complicated than it needed to be.
Hmm.
Whereas really, if you kind of go, well, hang on a minute, if the pelvis is going this way, what attaches there? Oh, quad fem attaches there. So we need to relax that. How are we going to do it? Well, we can do reciprocal inhibition or contract relax technique. Great, easy done. So once I kind of navigated the obscenely complicated language that I was originally taught, I went, oh no, this makes sense completely. Um,
So you think MET kind of simplified it for you,
no, the other way around.
or the
I
other
had
way
to
around, right?
apply MT. Yeah, yeah.
So
Um,
you found the PNF approach just simplified what you learnt with MET and the different variations of it.
um, yeah, I guess I never really thought about it as being. I mean, I learned MET as a technique.
Hmm.
PNF, we didn't really. I don't think we learnt it the way it's now
Right.
spoken of. So I think PNF, and I don't know, this is where I don't know what I don't know.
Mm.
But I get the sense that what people say is PNF now has become a whole technique, like MET is a whole philosophy.
Yeah,
PNF is a whole philosophy. Whereas when I learned it, it was just
a
a
technique.
physiological principle.
Mm.
You know, that after maximum tissue contraction, you get a short phase of maximum
Release.
relaxation. Well, can we
Uh,
use that? You
yeah.
know, reciprocal inhibition, if I activate one side of the joint, the other side has to relax by
Mm.
default. That simple, just basic physiological principle.
Yeah.
Um,
Well, that's how we were taught MET. We were taught MET in those basic in that basic. And I'm sure, like you said earlier, there's more complicated neurology behind it, and you can go there if you want to. But I think practically in the clinic, it's probably best that you don't do that because you got to get the job done. You got to get the work done. And so, okay, I was fascinated with your, I guess, take and approach to that, given that it was something that you learned. You've worked alongside osteopaths. Was that something that you enjoyed doing? Do you find that the osteopathic approach, I guess, the tendency towards, a holistic approach and the emphasis on the structure and the function, is that something that resonated with you? And did you kind of find that you practiced in a similar way anyway?
yeah, I think a lot of things I intuitively just discovered myself without necessarily being taught. But also, I would still put it in the framework of having, it's just a different religion. So there's different language to create a description for the same thing. We're all just trying to find our way because nobody knows. Because if anybody knew, then we'd all be doing that.
Hmm.
If anybody had the answer, then there would only be one thing that we do. So I think, we can all as practitioners get a little bit bogged down in but, my way is the best way.
Mm.
I've always been the opposite. I've always been a bit like, oh, well, I know what I do. Show me what you do. And why do you think that works? And okay, that's really different from the way I think. And then I might try and use my own language, I guess, to explain and rationalize the physiology behind a technique or a thinking.
Mm.
Um, Not to dismiss it, but to try and understand it and see whether I can use it.
Right.
So I think sometimes we can get carried away with all of our treatment philosophies in medicine,
Yeah.
and allied health, and say that something is true when it's not.
Right.
We have a belief in it, but we don't really know what the truth is.
No, I think, yeah, I think we know what we know, and I guess when you practice, you get results, and that reinforces your own bias. And that's not necessarily a bad thing. I mean, if you're biased towards getting good outcomes, then you're probably going to continue to get good outcomes. I guess where I was going with that is that to us as osteopaths, osteopathy is taught to us as a system of medicine rather than an actual approach to it. So, our approach to the musculoskeletal system would be in a similar fashion to how would we approach the pancreas, for example, and looking at things to do with that sense. Given that, has there been any time in your own private practice where you've seen a patient, you've, I guess, treated them for their ailment or musculoskeletal condition they've come in? They've said to you, you know what, Natalie, my groin's still sore, but for some reason, I'm able to take a piss now I haven't been able to take a piss for 5 years, and I can just go to the toilet a lot easier now. Is that something that you've experienced?
Oh yeah, all the time. I've been treating one thing and I've cured something accidentally that they usually haven't told me about.
Yeah.
So
How does your brain react to that? Like, how do you then kind of process that? Does that intrigue you? Is that something where you go, oh, I wonder what I've done? Or do you just kind of like, you just go roll with the punches and kind of keep going, doing what you're doing?
oh no, I always question. I'm a bit of a nerd that way. But I go back to be honest, anatomy and
Mm.
joining dots. But I would have to say that the more I work, the more comfortable I am saying to patients, I don't know. Um, like I'm so comfortable saying I have no
Yeah.
clue.
Yeah.
But I'll usually follow up with, but based on my knowledge and my education, which has its own intrinsic biases, um, this is how I'm joining the dots for you.
Yeah.
And I try and keep to the laws of physics and
Yep.
anatomy,
Yep.
because they're two things that I feel like they are truths.
Well, yeah, they've already been proven. We don't have to,
Yeah.
drop a brick off a building to find out that it, it goes down.
Yeah, don't get me started on one of the, influencer physiotherapists, PhDs, who's kind of implying that gravity doesn't exist the way I think the rest of the world knows that it
Right.
does.
Yeah.
Um, and managing to convince a whole bunch of people that, oh, no, it doesn't matter how you hold yourself. That's
Mm.
fine. It's like, it's called gravity. It's called posture. It's called alignment. Um, but yeah, like I think that comfort level with being able to say, I don't know, but also being able to
Mm.
come up with a very plausible, rational, scientific explanation has actually been quite valuable.
Yeah, it's an odd thing how we when we assess, for example, motor vehicles or bridges, aeroplanes, all these things that we really put our lives and our trust in. And we go on an aeroplane and we assume it's going to take off and it's going to land and it works because the laws of physics tell us that it's going to work. And we drive over a bridge every day and we're sure that it's not going to fall over and break because there's laws that govern its construction. Yet when it comes to the human body, when people say to you, "What evidence do you have for that?" and you're like, you know, have you not been
Yep.
paying attention? Like, it's like their faith in the laws of physics. They're happy to do that when they're driving over the Anzac Bridge or the Harbour Bridge or wherever you are. But yet, when it comes to, I guess, telling them how the the pelvis is going to affect the hip flexor. Oh, well, you got no evidence to suggest that. Like, okay, all right, I don't,
Yeah,
Um,
absolutely.
yeah, so I guess, okay, well, that's it's an interesting topic, and I guess the more experienced practitioners tend to kind of have the same viewpoint on that. I want to talk about your own, I guess, evolution to private practice, and what's been the most challenging thing for you in. Now, I want to move away from the clinical kind of setting. What's been the most challenging thing in terms of running that Bodyworks physiotherapy that you've got going on there?
Um, I think like the physio and allied health world has changed enormously in the last 20 years. As I said, when I was a little fledgling, it was very difficult to get into private practice. You stayed in the practice as an employee for a very long period of time. You were, not many people had the gumption to open their own business inside of 10 years. The experience was respected. I think there was a significant humility about the fact that until you had 10 years, you didn't really know what you were doing. And I think that when you opened your own practice, you were never within cooey of your previous employer. You went backwards quite a long way before you went forwards because you'd open the door, pay the rent, and if you saw one patient in the first week, you were thrilled. And then you took a number of years to build up over that time period. And I would say the single biggest shift happened with the internet.
Mm.
Reason being that, I previously worked at Edgecliff before I opened my own practice. The only way someone could find me, an ex-patient could find me, would be to open the yellow pages.
Mm.
Most of your listeners wouldn't even know what that was. So, so it was almost impossible to find a practitioner once they left the workplace that you
Yeah.
knew them as a patient in. We were pretty good at not actively soliciting, so you'd never tell the patient, well, this is where I'm going. That just wasn't done. But then with the internet, hey presto, if I want to find out where my hairdresser's moved to, I just type their name in and it pops up within milliseconds and I go, oh, cool, I'll go there then. So, clients aren't loyal to businesses, understandably. They're loyal to the hands that they have learnt to trust. So all of a sudden, you've got people being prepared to open businesses much, much earlier in their career because they go, well, I'm going to take a bunch of patients with me that I know will pay the rent from day one.
So has that been a challenging, have you faced that a few times? Has that been challenging for you in terms of having people come on board, you train them, you look after them, you groom them into, competent practitioners, and then all of a sudden they go, hey, I can do this on my own. A couple of years down the track, they're off and running and, starting up their own thing. Has that been quite a challenging thing for you?
Yeah, I think it has. It's been something that I think a lot of my peers discovered because we were the generation that, when I, again, was a fledgling physio, we got paid 100% commission. And the commission was 33%. No sick pay, no holiday pay, no nothing. And that was fine because you understood that that's how it was. So I think now it's much more challenging. I mean, I think it would be very, very difficult for anybody starting up a new business because now the wages pressure is so much higher that, at least when I was a young physio, my boss was earning good money from me whilst I was learning, and I was no threat to their business ongoing. Now, the profit margins are much, much more slender than they used to be. The risk is much higher, and staff are much happier to leave as soon as they feel that they have a good enough cohort of patients. They'll do the maths on what percentage of the patients that they are seeing in your practice can they move to their own. And I just think that's the way it is. But I think I was probably a bit slow to realize that that's how this is the new age. And I think we're probably going to turn around. And I think the smart therapists realize that actually, unless you're prepared to be a solo practitioner, where yes, you can earn good money, but you're working hard for it, you're actually better off to join together. And I think that's what we've seen with medical clinics. Now you have these massive clinics that have, a dozen doctors in them, because they've smartly worked out that, well, if all the overheads are shared, everybody wins. If you all go into your own clinic, you've all got your own overheads, and then you're waiting to employ somebody else to help pay those overheads for you. And I think osteopathy is in the same situation as physiotherapy and all allied health. There's a shortage of labour. So, who are you going to get to work for you?
Yeah, no, you're right. It's one of my previous guests who's run some pretty good allied health businesses himself. Kevin mentioned to me that he's learnt that you either have to go big or you go home. And what he means by that is that, you need to have 8, 9, 10 practitioners plus, or you just go and work on your own. And you assume that if you close your doors for a 4-week holiday, you're just not going to have any revenue, and you account for that and you're okay with that. Having 2 or 3 practitioners in a clinic is probably not feasible anymore. You need to either grow to a certain level where you can pull back and manage those other practitioners, or you just work on your own. And I guess the segue into the next question for you is, you seem like you are a very involved clinician, that you like to get your hands on, you actually enjoy it. How do you balance the need to actually continue to be a clinician and also run the business? Because I know of people who are good at running the business, but they don't tend to focus on the clinical aspect as much, or they're clinicians and they have clinic managers and people who do marketing and sales and so forth for them. Are you somebody who kind of dips into both, or have you just remained a
Yeah.
clinician?
No, I dip into both, but I think I'm a better clinician than I am a boss, that's for sure. Um, in terms of marketing the business, we haven't ever done any. And I think that, like, we are booked solid.
Well, put marketing aside, but I mean, even just the management of staff, right? Like that's a big. I think the biggest thing is people saying, managing your practitioners, managing the staff.
Yeah,
Probably the patients that you see don't even stress you out anymore, right? Like you don't look at your patient list and go, "Oh, geez, I'm having a tough day today." The tough part of the day is, 2 or 3 of the practitioners want to talk to you about holidays that they can't line up together. A couple of your admin staff, one of them's getting married and she's going away for 6 months, and another person's doing this, and you got to kind of juggle all this stuff together. That seems to be what practice owners are telling me are their biggest challenges. Do you align yourself with that? Is that something that's challenging for you?
yes, yes, it is. But probably the short answer is in terms of holidays lining up, I just say yes. I'm
Yeah.
just like, oh, just go.
Right.
Okay, you're getting married. Okay, we'll cover it. Like I think I am. I'm very aware. I have amazing staff, and I will
Mm,
bend over backwards to keep them. I know that there's a reality to the fact that I won't keep them for as long as perhaps people used to stay. But
mm,
most of my staff, even the ones that have left and opened up their own practice, I mean, the minimum they've been with me is about 5 years.
right.
I've had a lot of staff who've been, 8, 10 years. So yeah, look, the staff management is definitely way harder than the being a
Clinical.
clinician. Yeah,
Yeah.
and yes, to answer your question, I do get, like, the payroll and stuff is done offshore. I still have to check it over and do all the payables and all of that sort of stuff. But some of that I've managed to find an accounting group that has a bunch of Filipino people that do a great job and just give me everything I need. And every second Wednesday, I sit down all day and just go through.
Right.
all the stuff that I have to go through.
So, and how have you found balancing that with raising two children? I mean, you said that in the intro, you've got a couple of kids. How was that time of your life?
Well, my kids, my son has just sent me a message earlier tonight that he's moving out on Thursday. So my
You heard it here,
kid,
folks.
my kid is 26.
Yeah,
So
you heard it here
yeah,
first. If anyone
yeah.
knows Natalie, this is breaking news.
Well, he's been applying for ages, so he finally got somewhere in Sydney. So yeah, look, I think that was super tough in the early years when the kids were little,
Mm,
and I think uh, we didn't have support with family to help out or anything like that. So my husband and I had to be the sole caregivers of the children, which I certainly don't regret. But I think there's an element of uh, just reality check that something has to give.
mm,
And back sort of 30 odd years ago, there was this catchphrase of, can women have it all? And I'm like, yes, but they can't do it all. So I decided fairly early on that, you literally don't have enough time to do everything properly. And I am
mm.
a little bit of a perfectionist. So I went, right, well, I have to be prepared to let something go. And the thing I decided to let go was, okay, the house is going to be a mess.
Hmm.
Okay, the beds aren't going to be made. The
Yep.
kids' rooms aren't going to be tidy. I'm still going to cook every home meal, but if I'm too tired to clean up the kitchen before I go to bed, so be it. I'll do it on the weekend.
Mm,
So I think that was the thing for me that I kind of went, yep, something's got to give, and you just have to make a choice as to what that is. So
yep.
I think that you know I'm 57 now, and I'd say probably a decade or so, I sort of went, oh, happiness in life is understanding that you have to manage expectations,
Mm,
your own and those of the people around you. And if
yeah.
you can work that one out, you'll be fine.
Great. Good advice there for people. Um, I want to move on to, I guess, your particular views on the direction of physiotherapy and how that's changed in the last 20 years. Um, what do you think? What do you think's changed in physiotherapy over the last 20 years? And what are your thoughts on those changes? What is it that you like, and what is it that you don't like about what's going on in within your profession?
Yeah, well, you've possibly already got the sense that I kind of roll my eyes a bit with our evidence-based model. That again, I value the benefit of doing research, but I think it needs to be kept in context of a lab environment is very different from real world. Humans are immensely complex creatures. So even if, to think about your engineering discussion before about, bridges and physics
Mm,
and all that sort of stuff, and you go, yeah, but we have this extra thing being human that is the nervous system that we don't know, and we move, whereas bridges don't move. So it's an extra degree of complexity, and I feel like certainly now when I take students from various universities up here in Sydney, um, they can recite all the research papers to me on a topic, but they don't know how to communicate with a patient. They don't know how
mm,
to get information out of a history. Like they know how to ask all the questions, and then I go, but why are you asking the question? And they have no clue.
right.
And to me, that's the big thing. And to be honest, it was possibly missing a bit even when I trained. And I have spent my profession going, yeah, but why? But why? But why? But why? And all my students, when they leave, they're going, oh my God, that three-letter word. I've got Nat in my head. Why? 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 Give me some scientific plausible rationale. I don't feel like the clinical reasoning is as solid as it used to be, which is ironic because we never had a class called clinical reasoning. It just
Mm,
happened in our tutorial. Now they actually have a subject called clinical reasoning, and it isn't. And I think this, obviously, the big shift is towards exercise prescription.
right.
Um, and I have
Before you go on to exercise prescription, I want to stop you there for a minute, and I want to use your own argument against you.
excellent.
Why? Why? Why do you think this has happened? I mean, why do you think that you said that there's been a shift and that there's been, I mean, the clinical reasoning and the students can recite all these articles and papers and research and evidence, but yet when you get them in the clinic, they don't know why they're doing something. Why has that happened? So, what do you think are the factors that have led to that change in physiotherapy?
Okay, I actually think it started when I was in final year, no, third year physio. That it became clear that the physio profession wanted to be respected more by the medical fraternity. So they decided that if we have more students who do an honours, then maybe we'll get more people involved in research, because research is evidence and evidence is proof that, proof of concept. So when I was in third year, we were offered for a number of students, you can do an honours year, but it was included in your fourth year of physiotherapy. And I remember going, but that's not an honours, that you graduate and then you do an honours year and then you do a master's and a PhD. But no, they wanted to have more people graduating with honours. And I elected not to do it because I didn't see the point or the value. And some of my peers who did do it, they actually failed the basic physiotherapy course because they were spending so much time doing their honours project that they actually failed a couple of units. But they got pushed through because they were honours students and, well, this looks really bad if they fail the course. But, so I think it started there. It was this push to get more letters behind people's names and get more people involved in academia. And then university and education became big business. And then we could charge people for these masters and doctorate courses, which, again, aren't actually masters and doctorates. They're not further study in the field of physiotherapy, but you come out with more letters and it looks more impressive. So
Do you think it's true? Do you think it's true that medical physicians respect you more if you have an evidence base, that is backing up your profession? Do you think that's true? I mean, you said that you think the shift happened because of a need for respect from the medical fraternity. Do you think that's true? Do you think the medical fraternity does respect you more if you have, I guess, more letters behind your name?
I think it can. I think it varies. I think as a generalization, possibly. Excuse me.
Has it made a
Um,
difference in your particular practice in terms of how you, I guess, coordinate with general practitioners, surgeons, medical
no,
specialists?
not
Have
at
you
all.
found that they care about, that's okay. Do you think that they care about the letters behind your name, or do they care about the outcomes that you're getting for them?
I'm going to cough now.
All
Um,
right.
they care about the outcomes.
Mm,
I think, the problem is now you can't be a speaker at a conference unless you've done a PhD,
mm,
because, again, I find that incredibly ironic, because if I run off and do a PhD, I would see myself as being an expert in a tiny, tiny, tiny piece of one
mm,
topic. And I go, isn't it fascinating that people therefore think that you're better at everything
mm.
because you've spent a couple of years of your life focused on one tiny piece of an incredibly complex and huge puzzle? So I actually don't think patients genuinely care.
Well, patients don't
Um,
care. Patients care about outcomes.
Absolutely.
But
And to that extent, I don't know that specialists actually give a toss either.
mm,
I don't actually think I don't think they respect the allied health professions across the board. But the way you get that respect is, again, with outcomes with their
mm.
patients.
It's interesting that you say that because being an osteopath and listening to, I guess, medical professionals talk, whenever they refer to anything to do with musculoskeletal, they just automatically say physiotherapy. Um, It seems like an automatic. It seems to me and to a lot of other people that there's a really strong alliance between the medical establishment and physiotherapy. And I'm not saying that's a bad thing, but I'm just calling it out for what I see. Um, even to the point, like for example, I've got a great relationship with a couple of knee surgeons that I do very good work with, and they'll often write out their letter of surgery and their report, and I'll usually get it within 24 hours of them performing the surgery, and it's still, as much as they know me and I've had dinners with them and I've gone out with them and had a chat to them and gone on drinks somewhere, it'll still say, such and such patient is performing physiotherapy under the expert guidance of Sammy Karam. And I'm not going to sit there and call them up and say, "Hey, I'm not a physiotherapist." It is what it is, you know. And so to me, there seems like to be a really good relationship there. But from hearing you talk now, you just said that you feel like there's a lack of respect well, you get some of those vibes from the medical establishment towards not just physiotherapists but allied health in general, and that the only way that you can get their respect is by just getting outcomes for the patients. Do you see that from? I guess I look at it from the outside of physiotherapy looking in. Do you see it from the inside looking out? How there's a really strong alliance there between physiotherapists and I guess the medical fraternity. Can you see that?
Yeah, absolutely. And I think part of it is because we are in the hospitals.
Right. Yes.
So they, it's a naivety on the part of the medical fraternity that they don't know who osteopaths are. Most of them inherently hate chiropractors. And again, it's that whole religion thing that, the old school chiropractors that would use language like, your back's out and I have to
Yes.
put it back in,
Yes.
or, and actually, to be honest, I think one of the problems is the use of the title doctor, is that, you're not a doctor in their head. No, I'm a doctor, you're not a doctor. So
Yes.
I'd say that way more chiropractors are more liberal with using the doctor title, and medical doctors don't like that. They like to have that little, that little two-letter at the front of their name that
Yeah, that
make them
little
feel
that little
special.
power that little power thing on
Yeah,
top of yeah.
absolutely. 100%. So I think though that they at least learn who we are in the hospital system, or that's a
Yes.
double-edged sword, because a lot of my staff have been very frustrated over the years about the lack of respect from doctors about what
Right.
we do. And I said, yeah, but where do they learn about what we do? They learn about it from watching us in the hospitals where we're getting somebody up out of bed after a hip replacement, or doing a couple of deep breathing exercises, or giving somebody a pair of crutches. Okay, we're not really showcasing our knowledge and the fact that we can, do some amazing things with our hands. They get to do the amazing stuff in surgery. And, I've caused great amusement with a bunch of specialists, because I'll push back and say, yeah, for sure, doctors save lives, physios just make them worth living.
Yeah, that's a great
Um,
analogy.
and I have no problem with the medical hierarchy at all. I have no problem with the doctors being at the top of it. But again, I think, it's not, we need to stop focusing on it being a battle and needing to be respected by doctors. My focus is, am I respected by my patients?
Yeah. But this
Um,
this goes back to the question of, I guess,
where physio
what
went wrong. Yeah.
yeah, where physio. Well, I mean, I don't want to label it as being wrong because some people
Oh,
might
it's
listen to
wrong.
this. Right. Okay. So I'll let you do that. I agree with you. Okay. I agree with you, but I guess going back to that, you've I guess put some blame on physiotherapists wanting the recognition, the love, the admiration of people who they feel are a little bit on top of them in terms of the pecking order. And I guess once you realize that they're actually not on top of you in the pecking order, in as much as that they might be in terms of a regulatory perspective, but in terms of the patient, and that's who really matters. The patient sees you as just as important in their life as the surgeon. once you've done the work. I mean, once you've affected that patient's life, you generally have a bit more influence even what they do. I mean, you've done it a lot where a patient said to you, I've got this problem, who do I see? And you'll send them off to the surgeon. So I think surgeons and especially surgeons are starting to realize now that they need to work a bit closer with physiotherapists and osteopaths because we're on the ground, we're seeing the people first, and then we're having to obviously guide them and refer them. And that's been a product of the internet as well, you know. Before the GP used to control a lot of that. Nowadays, I know with my practice, I'll really direct the patient to the surgeon that I want them to see. I want to ask you. You mentioned that I guess that need for respect from physiotherapists has moved them towards getting more letters behind their name, and that means more academia and more research. Has that contributed to reducing the hands-on aspect of what physiotherapists are being taught in their tertiary education?
Um, ooh, I think it's related more to the topics that they choose to do research on, that has contributed to the hands-offness. So I think, chronic back pain, for example, has been one of the most researched topics, which is kind of ironic because acute back pain is the bigger number. And I've always said if you manage acute back pain properly, you won't have chronic back pain to have to manage. So how
Mm,
about we focus on managing acute stuff?
mm,
But because the chronicity means that it's just an ongoing entity, that's attracted a lot of interest in terms of research. And, we've now started to go around to going, oh, it's mainly a psychological, like using the biopsychosocial model. The focus now, the pendulum swung very heavily in the psycho part, and we've
mm.
forgotten about the bio part.
Yeah.
And I don't dismiss the fact that, probably when I was learning, it was more heavily on the bio. But, I recently remembered that why I had to do an independent study in final year of physiotherapy, and mine was the topic that I chose was the psychological factors affecting the onset of injury in athletes. So I'm going, we did the psycho stuff. We just didn't give it a label at the time. I've
Mm.
always incorporated it into my practice. I just didn't label it as such. Um, but I think that's been a huge part. And I think also because manual therapy is so difficult to research compared with exercise therapy, or as I call it, thoughts and prayers therapy, which is pain science. Um, uh, I think those things are much, much easier to create a methodology and have reliability and validity, inter-rater reliability. And I think it's way harder with a pair of hands,
Mm.
to try and get any form of consistency.
Yeah,
So it's
inter-rater
just hard.
reliabilities. Inter-rater reliability seems to be the very trendy um, go-to, I guess, variable when it comes to
Mm.
research. And the thing is, well, if somebody else can't reproduce it, it doesn't hold water. And I'm thinking, well, uh, there's there's talented. We mentioned this before. There's talented therapists, and there are therapists that are more talented and less talented, and there are therapists on different levels. And if I can get a technique to work for me, and you can't get a technique, the same technique to work for you, or forget even a technique, just an approach to a certain condition, a rationale, that is not a to say that my rationale doesn't work. It's just to say that you haven't been able to apply it in the
That's
same way that
right.
I've been able to apply it, and that there's nothing wrong with that, and that
Yeah.
I might be able to then help these people, and you might be able to help those people. So, this whole thing about inter-rater reliability being used as I guess, a straw man technique to really hammer down approaches to injuries. I'm trying to break this down. I don't want to talk too quantum, but approaches to injuries and approaches to treatment. It's not very intellectually honest. Would you agree with that?
Absolutely. And I think, one of the things underpinning all of this is ego. Why, as a physio, why do I care that I need to be respected by a doctor? Why do I care that you know, why is it so necessary that I can't be seen to be better at that technique than somebody else? Because as
Mm,
you've mentioned before, opera wants it to be a level playing field. You're not allowed to say you're better. That's strictly forbidden. And it's like, well, I'm not saying I'm better at everything. I'm just better at
mm,
this thing. But the ego gets in the way, and then we suddenly want to prove to everybody else that I'm better than you, and you shouldn't be able to do that. Whereas if we just
mm,
do 3 sets of 10 reps, then we take all of that out.
mm.
So I think that's missing what the patient wants.
Right.
So that's
A-
the next part of the topic.
And your approach to, I guess, the human body seems to be quite integrative. I would imagine that if someone sees you with a knee problem, you would definitely be looking above and below that particular knee in
Hmm.
terms of trying to put your treatment together. How do you feel about the exercise physiology approach of kind of breaking the body into bits and pieces? You know, you've got weak glutes, you've got a bad core, you've got a, this is the problem. Do you see that as being helpful in the health space, or do you see that as being something that we need to, I guess, address as either a physiotherapist or an osteopath? Do you see that, or do you agree or disagree? Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy and back to the show.
Look, I think all that anybody ever needs is just a set of clams exercises to do till the end of days, and everything will clams and plank,
Clams and
clams
planks.
and plank, and a couple of wall squats, and you'll be
Yeah.
fine.
Some glute bridges.
Glute bridges, maybe a couple of TheraBand rotator cuff
Yeah.
exercises, and then you'll be good.
I
Um,
wrote an article on the C word. You know, it's a really bad word, and I talked about the core.
yes. Well, again, it's like if you think about anatomy, it should all be actually quite self-evident. We don't have to overcomplicate it, and I feel like we have. But again, research has done that because if you choose the core, Gwen Joel et al. Up in Queensland University discovered the link between a weak TA and lower back pain, and then a decade or so later, it's like, oh no, that's stupid. That's dinosaur thinking. Ha ha! I can't believe people are still giving core exercises.
Yeah.
And you go, well, it has to be doing something. I mean, it's the thing that joins the pelvis to the torso. Like, give me any other muscle in the body that doesn't benefit from strengthening. Like, it's how
Well,
it's how you
everything benefits from strengthening, but
exactly.
I
It's
think
how it's
the whole system needs to be strong.
correct.
I don't think
And
you.
integrated.
That's
And
right.
integrated. So,
Yeah. Yeah.
yes, then there needs to be some, which is kind of to your point. Yes, I absolutely go above, below, and sometimes I end up treating a shoulder to fix a foot and vice
Yeah.
versa. And even I get confused as how I've ended up there, but it's like, oh, well, this is the way the
This
body's
is
kind of telling me.
this is how I play the
Um,
guitar, man.
Correct.
Yeah. Right.
So yeah, I think there's also, I could talk for an hour about what is weakness, because one of my new grads, his eyeballs were as big as saucers when I got him to do a dynamometric testing on a hamstring. And he got the strength readings, and then I treated the patient, and then I said, okay, test it again, and they were twice as good. And he's like, what happened? And I said, you've had a neurological effect. Like I said, he had inhibition before.
Hmm.
There was overactivity of the hamstring. It wasn't weak. It was already working when he was lying there doing nothing. So of
Yeah.
course he's come across as weak. So I think there's again a significant lack of genuine understanding. We use these phrases weak and tight, and so we
Mm.
stretch tight things and we strengthen weak things. And you go, but is it active tight or passive tight? It's only going to respond if it's passive tight to stretching. If it's active tension, then you've got to reduce the activity.
Mm.
And again, I think that physiotherapy doesn't do that very well, and exercise physiology definitely doesn't do that. And yes, breaking up the body into segments is again completely missing the laws of physics and biomechanics. Because when I do a bicep curl, it's not just my bicep that I'm activating. Like, I have to stabilize my scapula. Well, that means my thoracic spine has to be involved. And
Mm.
if you make the weight heavy enough, and I do this with my students, I go, can you feel your feet working when you do a bicep curl?
Yeah.
Because your center of gravity is further forward. So, of course, the whole posterior chain has to be activated. And they go, oh, yeah, like my feet are really, like I'm really having to, dorsiflex into the ground to stabilize. And I go, right. So, is it a elbow flexor exercise?
Mm.
And that's the
Yeah,
moment
definitely.
they go, oh my God, like, no, it's a total body exercise. And I go, yes, you might be more loading to the biceps or the elbow flexors, but um, every part of the body will be activated doing a bicep curl. So,
Yeah. Yeah, the concept of weakness and also, this is weak and this is strong. It's like, well, anatomy is anatomy, and anatomy will do what you ask it to do. And I
correct.
guess if you don't think something is firing, if that's what the terminology you want to use, well, just ask it to fire, get the anatomy right, treat the anatomy so that then the body can regulate and work in the way that it's meant to work, and then reassess and see what you've done and see if that's worked. And if that hasn't worked, then look elsewhere and just, start becoming a little bit of an investigator, in that sense.
Absolutely.
You've done a lot of work, Natalie, with athletes, and obviously you've delved and dipped into the strength aspect of, I guess, performance, but
Mhm.
that's also related into your private practice in terms of how you treat everyday people, mums and dads, and so forth. Um, in terms of getting people stronger and improving their tissue resilience, is that, I mean, when you look at improving strength, is it a matter of just improving their resilience to force? Are you trying to get them more resilient to the stresses of everyday life? Or are you specifically trying to make one thing stronger and another thing, active or non-active? Like, what's your philosophy behind that?
Okay. So despite having a very long CV filled with elite and professional athletes, I've never called myself a sports physio.
Hmm.
Because my personal take on sport is just it's human movement with a specific purpose. And I go, if I'm treating somebody's shoulder, I don't care if they throw a baseball, hit a tennis ball, hang the washing on the line, play lawn bowls. My job is to give them a perfectly functioning shoulder and the capacity to do anything with it, because it's not for me to decide whether they might decide to take up tennis next week, even though they never have before. So I personally, and it's a bit of a different take on sport. Um, and to that end, I'm a big fan of functional exercise training too. So it's very rare for me to give anybody, including a sports person, but specifically a non-sports person, an exercise that doesn't look something like what they would do in their normal everyday, which is why I hate plank, because I don't dispute the fact that it strengthens everything, but
But,
what
but no
what
one ever
task
does it.
what task do you do on your
Yeah.
toes and elbows, contracting every muscle of your body for 2 minutes at a time, not moving? Key point there.
Yeah.
So to me, unless you're training to be the first human coffee table, I
Yeah.
won't give it as an exercise, because again, you might get the sense that I'm really fascinated by the brain, but to me, a strength of a muscle, it has to be put into a task, and that task is multiple muscles involved in movement, and the brain needs to practice that sequence of firing to get it all coordinated together. So why am I giving an isolated muscle
Mm.
activation, even though it's not really isolated, when I'm wanting the movement to be a functional one that
Yeah.
incorporates multiple joints.
Yeah, the concept of isolation is a bit of a fallacy. I think that's we should really move on from that. But so you're a fan of like more compound movements, squats, deadlifts, overhead pressing, pulling, pushing,
Yeah,
carrying, that kind of thing. Is that, you're trying to incorporate those kinds of things into your practice?
yeah, absolutely. I mean, I do a lot of exercise prescriptions, so I'm definitely not against it. I
Yeah,
incorporate it with every patient. But
right.
I won't give every patient, 20 exercises to do. And
Hmm.
we usually have a pretty realistic discussion at the beginning about whether there's a high risk of them actually doing the
Hmm.
exercises. So I go, look, I'm a realist. If you're not going to do them, let's not give
Yeah.
them to you.
I always say that if I have to give someone more than 3 exercises, I haven't done my job right in the clinic. Would you
Yeah.
agree with that?
Um, Yeah, again, I think it comes down to the patient goals, like what they want to do. And I think this is also a direction where I feel physio has got a little bit misguided because there's a huge discussion and vocalization around the term empowerment. Now, we have to empower our patients to self manage. We
Yeah.
must empower them to self manage. And I go, no, you do realize that's dictating. And they
Yeah.
go, what? And I go, no, you're dictating to them that they must self manage. That's not empowering them. Empowering them is giving them the choice to be masters of their own destiny. And you need to give your professional advice. And here are all the things you can do. This is what I recommend is probably going to have the highest risk of you having the best outcome. But what is it that you want to do?
Yeah.
Empowering people to self manage is absolutely not
Yeah.
empowering them.
Yeah. As soon as I read that in the bio of a practitioner, I want to empower my patients to do this. I'm thinking, oh, geez, like it's the word empowerment seems it's the language of kind of new age coaches and life coaches and people that are, I guess, trying to use fancy words to sell something. But you're right. I totally agree with that. One thing I do want to ask you on the strength field, and I've asked this to a couple of people, they haven't really been able to give me a really good answer. I have
Oh,
my own take on
challenge.
it. So I'm going to ask you
Challenge.
the question. Um, what is strength?
Oh, yeah, that is a good question.
Define strength. What is strength? Simply.
Um, is the capacity for the human body to generate enough muscle activity to perform a task?
Right. Okay. That's good. I defined it as the application of force against an external resistance.
Yeah.
Yeah. And so by that means we can measure strength through force application. And it usually comes down to, force equals mass times acceleration. And the
Hmm.
mass is the bit that we really can change. So, and what I mean by that is that improving tissue resilience becomes the center of what I try to do with strength development. And I want to get their tissues more resilient to the stresses of everyday life. And what can I do in this with this patient holistically so that I can get them just functioning better, closer to the optimal regulated state of their body. And I think if you keep it in that simple sense and you don't overcomplicate it, you probably throw out maybe 5 different colors of TheraBands. You throw those in the rubbish, and you end up, using very basic equipment and not having to have the fancy gyms that we see in a lot of practices these days. Um, so moving on to my last question with you, and this has been very fascinating talking to you. What lessons do you think that we can learn as osteopaths? And I've been asking a lot about what you do, and I'm going to try to be a bit more selfish towards our profession right now, and asking you to give us some guidance. I mean, one of the things I will ask you before I ask that question. We've got a movement happening at the moment with what we call advanced titling, and you've refused to call yourself a sports osteopath, or sorry, a sports physiotherapist. There's a movement now within the osteopathic profession to give osteopaths titles based on extra learning,
Hmm.
extra credentials that they've achieved. And so, you could be a pediatric osteopath, you could be an advanced sports osteopath, a pain management osteopath, or whatever. How do you feel about those titles being given out to, I guess, therapists, whether they're physiotherapists or osteopaths? Do you see that as something that's been a good thing for physiotherapy, or do you see that as something that's maybe not been such a good thing?
And again, we've had the titled sports or manipulative or whatever
Mm.
that they've been around for, I don't know, a couple of decades now. I think probably not 20, but 15 years.
Yeah, we're just doing them
Um,
now.
yeah. Look, at the end of the day, I don't know that they make a hell of a lot of difference to, again, the patients. Um, it can have the opposite effect too. It's the same with, physio now offers a doctorate course at both Sydney and Macquarie universities up in Sydney, and it's taking kids who did a basic science degree, and then the doctorate course is an additional 3 years after their science degree. Now, I take these students as on their clinical rotations. Um, they're no better than the undergraduates that took 4 years to do physiotherapy. They've arguably just taken longer time to get to the same place.
Mm.
Now, the irony is that they come out with the extra letters, Doctor of Physiotherapy. Um, excuse me. The the downside can be that um, if the patient thinks that now I'm seeing the best form of physiotherapist because they have the extra letters, and that person isn't very good, excuse me, it has a negative effect on the entire profession, because people go, well, I saw the doctor, I saw the highest level of
Mm.
physiotherapy, and they didn't get me better. So what's the point of seeing a regular physio because the best person didn't fix me?
Mm.
So I think we need to be very careful about um, what that actually means to get these extra titles. And again, I think fundamentally it still comes back to, I mean, we've got a local title sports physio. In the last 6 months, I've seen more of his patients than pretty much any other physio on the beaches, because he's just not doing what the patients need him to do. And they might start there because he's got the title, but proof is still in the pudding. So I don't think that it actually makes you necessarily a better
Mm.
clinician just because you've gone and learned a heap more stuff.
Yeah, the
Um,
the you're right, and I think it's the danger is when you have somebody that's 2 or 3 years out of practice, and then they go, you know what, I might go do this little PhD or something that might take them an extra year, and they go and do it, and then now they've got the advanced title, but they haven't seen the amount of patients that it would need for them to actually get the real world experience to kind of be able to make a change in complicated or patients that are looking for that particular field of interest. And so that is a little bit dangerous, and that's been my particular take on it. So I want to get your take on it, and I guess then that let me get to the final question is, what do you think osteopaths or osteopathy as a profession? What do you think we can learn from what the physiotherapy experience has been over the last 20 years? Where do you, if you were giving us advice, what would you tell us to do, and what would you tell us not to do in terms of making sure that, I guess, we don't lose the uniqueness of what we do as osteopaths, which is I guess, our approach to our hands-on approach, our rationale, our thought process, our philosophy. And I know you said that everybody's got their own little kind of religion about what goes on, but I guess we need that. I think we need that in the space because it's good to have points of difference, and it gives the market more, I guess, consumer choice. And so, how do we as osteopaths not let our uniqueness be kind of just diverged into this evidence-based exercise approach, mold that we see that's happened now with physiotherapy?
yeah, well, I say to a lot of patients, to coin that old phrase, it takes a village, right? Takes a village to raise a child. So I usually say it sure as hell takes plenty of practitioners to raise an adult to some degree of health. And I said, you've just got to find your own village, and it's not just one person. Like it's
Mm.
rarely is it one practitioner of any of the disciplines in medicine, and because it fundamentally comes down to humans being incredibly complex creatures. So I will stay in my lane and do what I think is right, but that's why I love working with osteopaths and chiropractors and GPs and specialists, because it's like, well, look, I've taken care of what I can take care of, but we still have a human here that's not 100%. So
Mm.
can you see if there's something that you can do? And I look at it as, again, if there was only ever one restaurant that everybody, like, okay, you've all got to have Italian food because it's just the best food on the face of the planet. And you go, but I don't like Italian. Why am I eating it? So I think, to have the diversity in healthcare like we have in cuisine is not entirely a bad thing. And I think it's super important that you be good at being you, and don't worry about what the physio does. And it's not a race to the bottom or the top. Just focus on your client and be humble about the fact that you've got a piece of the puzzle, but you mightn't have all of it. And that's absolutely okay. And if you have the client's welfare front and foremost, then you will be great at what you do. In terms of where osteopathy is at the moment, I think you have an amazing opportunity to capture what physio is losing, because I don't think I've ever been busier than I am now. My wait list is blowing out to a month. People, which is not good. You don't want people being in pain for a month before they can see me. But the reputation has got such that they're like, I'll see it in the diary, only seeing that. And they will wait a month to see me. And I think the reason is because there are now so many physios that are doing just exercise prescription and not even smart exercise prescription. And they're missing what the consumer wants. So it's all well and good for us to wave the research and say, oh, but, we know that exercises are better for people in the long term. It's like, yeah, but your customer wants short term. Oh, you need to empower your patient by giving them self-care strategies. The whole reason they've come to you is because they don't want to fix it themselves most of the time. They want to hand that over. They're happy to pay for somebody else to take that burden away. Oh, you shouldn't do, it's passive care. All right, I understand if it's third-party payees and, in the public system where we can't afford to do one-on-one treatment, heaven forbid, or, workers' comp where it's like, well, yes, it might be an open checkbook for some clinicians to keep treating and patients just want to turn up for a little bit of a rub, and that's all very nice. But the genuinely private sector, like, I'm not going to tell somebody where they should spend their money. And if they want to pay me to lie there and have me take all of their musculoskeletal troubles away with my hands, then that's their privilege and right to do so. And it's not up to me to say, no, you will not have my hands, you must do exercises, unless that's what they want. So I feel like, what I'm hearing from so many patients at the moment, and again, I've never before seen so many patients that have come from other clinics, as I have in the last 6 to 12 months, and almost verbatim, they will say, oh, I went and saw, the place down the road 3 or 4 times, but they just gave me a couple of stupid exercises.
They didn't touch
and
it.
And they will add in the stupid.
Mm.
And I go, right, well, even if the clinician has given the exercises, they haven't explained why they're giving the exercises. So, and patients live busy lives. Exercises tend to be boring. And I often say, well, if you don't actually explain to the patient why you're doing it, their motivation for doing it is even less than it otherwise would be. So I think that there is a huge opportunity for osteopaths to capture the market of the customer who just wants that touch. Because that it works. That you can get great results with it. And that it's something that the patient can walk in with pain and walk out without pain. And I don't know a single exercise on the face of the planet that has that power. but we have it in our hands, and we should keep using it.
So do you think that, I mean, how do we as a profession stop the slide down that way? I mean, what happened in physiotherapy? Were there any bad actors that you feel is kind of like, if you were just sitting in a room and taking out the people in the history of physiotherapy over the last 30 years, you'd say to that bloke, you get out, mate. You've had a bad influence on where we're going with this thing. How do we as osteopaths, I guess, identify what are some of the slippery slopes for us? You mentioned earlier about wanting to, have the respect of the medical establishment. I would probably assume that you'd give us that advice is, hey, don't worry about, worry about yourself. Don't worry about trying to get the respect of anyone else, and focus on what you do really well. But is there any advice you can give in that sense as a profession? Have you seen some really big turning points within physiotherapy that you can identify as, aha, this is something that we did that really changed the face of education, the university structures changed, education changed. And please, Sammy, if your listeners are listening to this, don't do this within osteopathy. Is there something like that you can offer, or is that something that, am I asking the wrong question?
I might be answering it the wrong way, but one piece of advice I would give is keep thinking. Because I think what social media has done has created these influencers that are preaching their version of something that people without thought are just lapping up, and they're not critically evaluating it. Hence why we've got so many people doing clams as an exercise for, gluteus medius strengthening. And you go, can you analyze it? You're doing a femoral rotation. Does the glute med primarily rotate the femur, or does it abduct the femur? Why aren't you doing an abduction, and why are you doing it lying on the ground? Why aren't you doing it standing? But everybody does it. We're suffering an earth is flat mentality where it's, I don't think it is, but the earth was flat because everybody said it was, not because it was. And to me, it's the lack of actual independent thought. And I feel like certainly physios, I don't know if it's happening in osteopathy, they're almost scared to think independently. And I don't mean make stuff up. I mean actually analyze what's being said and go, does it meet with the laws of science? In terms of, research, they grab hold of the clickbait of the abstract title. And then you go, okay, but delve into the methodology, pull it to pieces, discover all the flaws in it. Don't throw out the research paper because they're all flawed in one way, shape, or another. But what can you get from it, and what do you need to ditch from it? So to me, all of that takes critical thinking. And I think that, to be honest, if I'm going to go really deep, it got lost at secondary education. Because now to get the 98, 99 ATAR, you need to get into physiotherapy. I'm not sure what it is for osteopathy. It's pretty high, I'm sure. You have to have a really good memory, because the way to get a high ATAR is to be able to regurgitate pre-programmed information. Now, to me, you're not necessarily good at problem solving just because you have a good memory. And what I see students of physiotherapy coming in with, they've got their 99 ATARs and they say, tell me the protocol. Tell me what I need to do. So they're not actually thinking, they're not joining the dots. They're regurgitating the pre-programmed information, and then they're waving the research papers saying, see, I'm right, and here's the proof. And it actually diminishes their need to justify themselves, because they go, well, they said it, so it's not my fault if it's wrong because the research said it.
Yeah.
And I think that's kind of where we've gone to is way back from secondary school. We haven't realised that we're not teaching our tertiary educated students how to think.
So how do you I guess put a bit of a firewall against that? Do you feel that the stakeholders within physiotherapy have been captured? Associations, the Physiotherapy Association, education facilities, educators. Do you feel that there's been have they been captured And are they still, I guess, advocating for the betterment of the profession, or are they just like business as usual? As long as things keep going and things keep going the way they are, we're kind of happy.
I think we're still in a phase where everybody's drunk the Kool-Aid. It's still coming back to research is everything, and we've forgotten the need of the patient in front of us. And then you add in the extra layer, and one of the reasons why I'm pushing so heavily for manual therapy and why I think there's a great opportunity in the future for osteopaths is it's AI proof.
Mm. Yeah,
It's real intelligence, not
yeah,
artificial. It's
yeah,
the one thing that Chat GPT can't produce. Like anything exercise based,
yeah.
you give Chat GPT an instruction you give it a diagnosis, make me a 6 weeks exercise program and link me to YouTube videos that will show me. Because, of course, all of these
Mm.
practitioners went on YouTube and gave all of their exercises because they wanted to be,
Content
influencers
kings.
and,
Yeah,
yeah, content kings. And you go, great, you have just provided to the universe
yeah,
that which you're then in the future expecting them to pay you for.
yeah.
Okay, well,
And
AI has
ChatGPT's been doing a better job now.
absolutely.
Yeah,
Okay, so you
right.
kind of go, this is just ludicrous that we're moving away from the one thing that is guaranteed to
Yeah.
keep you employed
Natalie, have you
because
spoke?
robots are never going to be able to make it.
Have you spoken up about this within your own profession? Like, are you somebody who's gone to the association and said, "Hey, I'm dealing with a lot of students here. They can't join the dots. Something's happened at our education institutions. I've had to put in many, many more hours of educating early graduates. We've lost the plot in terms of giving them what the public wants as physiotherapists. Have you been vocal about that? And how's that been
um,
received? If you have been vocal about it,
I guess I'm slowly, gently joining a group that, we're all old school. We're all sort of think the same way. It's not my nature to be, I'm inherently conflict averse, so I don't really like to challenge people, but
mm.
at the same time, I'm so passionate about what I
Yeah,
do,
your passion comes across.
and to be honest, I fear for patients because, whilst it's great for my ego when they come and say, oh, well, I saw this physio for X number of weeks and you've literally fixed it in one session, or I'll listen to their story. And on the one hand, I could kind of be super proud that it's like, oh, I've got this. I'm going to fix you. This is how awesome I am. I actually get genuinely upset. I get
Mm.
genuinely distressed that here's a patient who, I had a girl the other day, 4 years. She's been going around to doctors and physios, and then they send her to the pain management center for her back pain. She's 22 years old. She was an elite athlete. Nobody has touched her. They just keep giving her
Mm.
exercises. And I just put my hands onto her and I went, this is a mess. And in one treatment, she's saying she's 80% better.
Mm.
Now, I'm going, that just breaks my heart that that girl has, she's lost confidence in her body. She now feels broken. Like, we could talk for hours on the
Mm.
ramifications of what's happening. Um, my next endeavor is I'm going to see whether I can actually become a teacher at the university level because I'm like, okay, well, I've always been a believer that you can't, can something without getting in and trying to change it, which is kind of like,
Mm.
I guess, the point of your question. But I think it needs to happen at grassroots level. I think, contacting APRA or our professional association or something and saying, hey, this isn't working, they're not going to care.
Mm.
They're still so invested in the research is everything, and you know, because I haven't got a PhD, I don't get to have a voice.
Right.
Is what it comes down to. It's like go away and do a PhD, and then come back, and we might listen to you.
Yeah.
And I think that, and that's not something that I ever want to do. Because I'd be doing the PhD for the wrong reason.
Mm.
I've got 127 PhDs that I'd love to have an answer to, but that's not how. Again, that's not how research works. You can't go blue ocean. I can't decide that I've discovered this. can I look at that? It's like, no, you have to actually expand from you've got to get a supervisor. So you have to expand from the research that's already in existence. So we have this model where, we start here and we're going out here like this, but I want to check something out over here. Okay, wait another 45 years until we've spread to that point, and then we'll look at it.
Yeah.
So there's lots of things inherently wrong with how we actually go about research itself, which I think, again, I don't diminish the value of it, but I don't think it's the be-all and end-all of existence. Exercise is fabulous. Humans need to move. They need to be strong. We spend far too much time sitting, from a very young age. I think the rot sets in at the age of 5 when we sit kids down, and during a very important developmental phase when they're becoming adults, they're not moving terribly much. So, exercise is absolutely beneficial, but
diet too.
Absolutely. Diet, socialization, all of those pillars that we know to be really intrinsic in health. But I think, in terms of allied health, what can we do? How can we be of service to the community? Because fundamentally, if you work in health, that's what your role is. You sure as hell don't do it to make lots of money.
No.
I think we all know that. So if you're going to be genuinely of service, you need to be listening to the people that you are going to be of service to, and they are your clients, your patients. They're not the governing body. They're not APRA. They're not doctors saying, well, I want you to increase the range of motion and give them some strengthening exercises. It comes back to, dear patient, what do you need me to help you with?
Yeah,
and
definitely.
then make sure you tick that box. And if you're not consistently meeting their requirements, then you need to do some reflection and some learning and some redevelopment of your skills.
Definitely great advice. I'll leave it at that tonight, because it's been a really engaging conversation, very interesting for me, because I think it's opened my eyes to some things. I wasn't aware of some of the challenges that physiotherapy was going through, and I guess it's good also to see that there's still vocal people who are interested in keeping manual therapy in physiotherapy. I had a really good influence as a young soccer player myself, with a physiotherapist named David Hughes over in Sydney, who used to look after all the players at the New South Wales Soccer Federation. And he was very hands-on and very thorough with his history taking and his understanding of biomechanics, similar to everything that you described. So there's certainly been a shift within physiotherapy. Your insights into that shift, and also some of the, I guess, the curveballs that physiotherapy has had to work through, has been a really good insight into what osteopathy is facing as well. We're a growing profession, and we're bound to come up against those barriers, and it's good that you highlighted them. And so with that, I want to thank you for your time tonight. Stay on the line with me. But for everyone else, this will be the end of the episode. Join me on the next episode next week. But Natalie, thank you very much.
Thank you so much for having me.